Hello and welcome everyone for tonight's EAO Just Ask. Tonight it's an amazing pleasure for me to welcome on behalf of the EAO Professor Nadja Nänni. Nadja, it's such a pleasure to have you here. Everyone is waiting for you. We have a lot of people logging in from Spain, from Saudi Arabia, people all around the world. And the EAO and me, I would like to welcome you. And I have to say one thing. You are the very first guest preparing a perfect background slide for the Just Ask. This is how the Swiss prepare. Nadja, welcome to tonight's show.
Thank you very much, Stefan. Thank you very much, EAO, for the kind invitation. And I actually realized today this is the 50th kind of screening of the EAO Just Ask. So I think I should have a nice background.
Wow, I actually didn't know that. So that is a little bit like having birthday. So
Yes.
so thank you for that. So let's make it a perfect Just Ask, and I'm more than sure it will be one. I don't think I need to really introduce you. You're world famous. You're traveling all the world. You are from the top-notch university, Department of Reconstructive Prosthodontics of Zurich, Switzerland. And you also had affiliations in Sweden. You did your habilitation, PhD. You published all around. We always read your names on the lecture podium. So your expertise is of course prosthodontics. But tonight we have a very, very, very special topic. It's not so much about blood. It's not so much about screws. It's, I think, even more important. It's about patient expectations. So a little bit, what do we want to see from a case? And what actually does the patient expect from us? So with this, again, a very warm welcome. And we're very, very much looking forward to that session, Nadja.
Thank you so much, Stefan.
Nadja, actually, a patient stopped by today in my office and she requested root coverage. I know it's not totally your topic, but still, I thought about you because she has a low smile line. She has a very, very mild recession. She's in her 50s, so I think the recession have come a long way. So it took a long time to develop this mild recession. And she requests recession coverage. And I'm not sure what to do because I know it's a quite invasive procedure. I will have to graft from the palate. I will have to do surgery here. We have to give her antibiotics and so on. And I know as a dentist, maybe she doesn't really benefit from that from a medical perspective. So I knew I'm going to have you and we're going to talk about patient perspectives. And I just thought, I'm going to ask you. So what should I do? Should I graft or should I not graft? What would you recommend?
This is a tricky question, asking a restorative dentist, Stefan. But I think it's really nice that you are saying the patient came with a wish maybe for a treatment. The thing that we really need to know, what does the literature say? How are the chances that you can cover these recessions? That would be the first point. Then you can explain to your patient, this is going to be the procedure, or there are maybe different types of procedures, and this is a possible outcome that you can expect. Now, maybe you want to know whether your patient can really differentiate between the baseline, the situation that she has now, and can compare it to the situation that she will have after you have treated her. And there you have to find kind of a balance between an efficacy of a treatment and the burden that you lay upon your patient. And this should really be kind of a joint conversation and then kind of a joint decision-making process. And this way, I think you can decide whether you want to offer your patient this certain treatment, whether the patient will profit from the treatment, and maybe you can also foresee whether the patient will be happy with the outcome of the treatment. Because if I
should
say,
I not only
yes,
like put in my medical thinking, but also maybe I help her with her self-esteem? Is that something I should think of too?
I would say absolutely. I would say, you know, this is something that we should discuss with our patients. How much is this situation a burden in your daily life? How much maybe do you suffer from tooth sensibility? How good can you eat ice cream if you love ice cream? How well can you laugh? Does it disturb you? You said the patient has a low lip line. Maybe she doesn't even show it. I think these are quite important points that you have to find out during the discussion that you have with your patient. And then you can decide whether she will, or together with the patient, she can decide whether she will benefit from a certain type of
Perfect,
treatment.
Nadja. I think that helps me a lot. I'm not sure if everyone has seen the picture, but it was just a Miller class 1 quite mild recession, which we have been talking about. So I'm not sure if we technically can manage to show the picture, everyone. That's why I wanted just to describe everyone the picture. Nadja, we want to have your knowledge. We want to know how to treat patients the right way. We want to know what should we do as a dentist, maybe also as a presenter, as a lecturer. We maybe have different views on patients because we sometimes think, oh, it's a good case for documentation. So maybe help us with that. I think it's an amazing topic. Everyone is looking forward to that topic in the chat. I have it here. Please, you have the expert here. Type in your question. I will hand over to Nadja. Nadja, we are more than happy to hear your presentation. And as it is a little bit the tradition of this Just Ask, I just allow me to interrupt at any point. It's not unpolite. It's just making it a nice conversation. And with this, I would love to hear your input.
Absolutely. Thank you so much, Stefan. And I'm really happy that you mentioned the stage, that sometimes we want to show a nice case, but we really have to try and stick to the fact that we should put the patient at the center of our decisions and at the center of how we maybe do a treatment or maybe not do a treatment. And we all want to show these nice clinical pictures, but maybe the patient doesn't even perceive it as nice, or the patient doesn't want to have this certain treatment. So I think I just want to sensitize you a bit regarding these questions. And I would like to start with showing you one of my patients that has been with me for many, many years, I have to say. And on the left-hand side, you see also recessions. Stefan, maybe I should have talked to you before I treated the patient, but she actually had two crowns already, tooth-borne crowns on the two central incisors, and the tooth one was failing due to recurrent endodontic complications. So the patient told me, you know, if I will have a treatment, I will follow you. That was the time when I was in private practice after I graduated, when I was going back to university. And she said, you know, I'm going to follow you. I'm going to come with you to the university, and I want you to treat my two central incisors. Now I fast forward. On the right-hand side, you already see the end result. And we will have a bit of a closer look at this patient. And I would like to ask you and also show you, how do we get from left to right? What does it take to get from left to right? And what do I have to tell my patient? How do I inform my patients? And how do I also manage the expectations that the patient most probably has? And I would like to disclose in a fast forward green arrow all the steps that I did during this treatment. And I can tell you this treatment procedure, or the treatment time, lasted for approximately 1.5 years. And you see, I started with tooth extraction. I did a ridge preservation procedure. I placed an implant. I did a GBR procedure. I even did a soft tissue augmentation procedure. So it was quite an intensive, long treatment time for the patient. But at the end, if we talk about patient expectations, you see, I have a happy patient. And this is really what makes us all very happy, I would say, at the end of the day. When you leave your practice and you have patients that have come in, You maybe have seen them at the regular recall, and they tell you, you know, I'm really happy and satisfied with the outcome.
Nadja, I have a first question. It's a beautiful case. Congratulations. My question would be, would you have performed the same way if she has a low lip line?
It's a very good question. You know, today, I think I have to tell you that this case was treated maybe 10 years ago or even more. And today, I think a lot of these techniques or treatment options have changed. So I would probably today go for a different approach. If she had a low lip line, I would certainly discuss with her how important the aesthetics or maybe the length in terms of cervical length of the teeth is to her. Whether she would end up with maybe longer central incisors compared with the laterals and the canines. And I think we have to work with pictures. And, you know, I always tell the patients, when you go to the hairdresser and they cut your hair too short, it may be annoying, but you can wait for the hair to grow back. If we do
not everyone.
Yes, but if we do a dental treatment, yes, we can do redentistry, but it's going to be costly. It's going to take a lot of time. You're going to have a lot of pain, probably. So I think it's a different thing. And we have to try to get the patient to the same page that we are. And we have this immense knowledge and we can maybe anticipate the possible outcome. But for the patient, this is so difficult to foresee a possible outcome. So we work a lot with mock-ups that we try intraorally if possible. If not possible, we do a lot of digital mock-ups or maybe some videos even to really try and show the patient what an outcome could look like. And only when we have the consent of the patient do we start with the treatment. Yes. So maybe I would have treated her differently if she had a lower lip line. Maybe I would not have done that many surgeries, yes, in hindsight.
But it's sometimes difficult also, I mean, to clearly say a procedure we do because of aesthetic purposes. I mean, we also know a connective tissue graft helps you maybe in terms of bone preservation or long-term maintenance. So it's a very, very difficult way to decide that, right?
It's a thin line sometimes, yes. Yeah. Also patients sometimes they ask, what is the benefit? Is it aesthetic? Is it health-wise? You know, what benefit do I have? And then sometimes it's really questions that are difficult to answer. Maybe we can answer with some evidence that we do have, but in a lot of cases we do not have evidence. Yeah. So should I go on with the next case? Because it's really a very opposite type of treatment.
Yeah.
So this is a young patient and she was referred by her orthodontist. You again see the baseline situation on the left-hand side. She was actually smiling, although I felt very sorry for her because she was walking around with this situation for quite a long time. This is at the end of her orthodontic treatment. But the orthodontist thought, well, she can live with this situation. And this is actually the first time that I had seen the patient. On the right-hand side, you see the final result. And now if we go back to the question that I have asked in the first or with the first clinical case, I would again like to make you think, what does it take to get from left to right? What can you offer this patient in terms of treatment time, in terms of invasivity, in terms of possible outcomes? And I would like again to fast forward a bit. And now you see there are only a few steps that I took. I extracted the tooth. I again did a ridge preservation procedure because I started with a deficit to begin with. Then I let the tissues heal and I did a tooth-borne reconstruction. In this case, I placed a resin-bonded bridge. Now, if we go back, we have two very happy patients. On the left-hand side, the patient with more than 10 years follow-up. On the right-hand side, the patient that I saw last week for her 5-year follow-up. And I asked her, you know, what do you think of the reconstruction? Are you still happy? Are you satisfied? And she said, I'm really, really happy. And I totally forgot that this is not my natural tooth. So now, what I would like to ask all of you, and what we ask ourselves probably daily in practice, if a new patient comes in tomorrow, which option do I choose? Do I go for maybe an implant-based restoration? Do I go for a maybe less invasive type of reconstruction? In this case, a resin bonded bridge. So I want to take you on this journey regarding decision making, and we do have some.
Nadja, can I go back to
these
2 cases, because I find it interesting that there's an age deviation between these 2 patients.
Yes,
so
I know.
My question would be, does the age play a role in both ways concerning invasivity, but also long-term maintenance of the reconstruction?
Yes. Thank you very much for this question. And this will also, I will touch upon this question in the next slides. But you are totally right. With the first patient, it was a fully grown patient, and I was very confident I could place an implant even in the aesthetic area. Although we know there might be some changes, we might end up with some vertical steps even in fully grown patients. And actually this patient developed a type of a step over time. On the other hand, I have this young patient that was too young for placing an implant. She was in her teens, and I am very hesitant, especially in the aesthetic anterior area, to place implants in young adults. So usually we say 20, maybe 25 years old, so then they are fully grown, but still we do see quite some cases, and there's also quite a body of evidence telling us that there might be steps over time in the occlusion because we have constant changing over time, even though the growth should be kind of, or should have ended at some point in time.
But do you also sometimes, I mean, it's so interesting now, Nadja, we already started discussing, sorry for interrupting so many times, but it's so interesting. But do you also consider like dynamic changes over time? I mean, we do that in periodontics. We know maybe this tooth will last for another 10 years. And then we say, okay, we're going to keep it 10 more years, and then we still can place the implant. Is that also sometimes a thinking you have as a prosthodontist?
Yes, absolutely. Thank you so much. We are so much alike, not so much apart from each other, I realize.
True.
Yes, actually, you know, for a resin bonded bridge, it is a final solution. And it is a solution that has a wide body of evidence I will show later on. And it is a solution that works very, very well. So if I would have to choose for myself, or maybe we always say, you know, you have to ask yourself this daughter question or this sister question, or how would you treat them? Probably my first choice, if possible, would be a resin bonded bridge. It's not it doesn't come with a lot of invasiveness, with a lot of surgical interventions. It doesn't have as many risks regarding especially biological complications. Mm-hmm. And if the patient ever has the wish for a new reconstruction or a new restoration, you could still go for an implant placement. So I am really trying to place implants as late as possible. So I would say we are very much alike, Stefan. I would like to have a second option. If anything happens, you know, over the course of time, maybe in 5, 10, 15 years, I still have a plan B. And I think this is for us very important. So when we plan, we always also discuss with the patient, you know, different options. And then we always say, you know, if something happens, we can still go left or right, and we have to try not to kind of interfere with our own decisions. Yes, I think that's very, very important.
Thank you.
Yes. So coming back to the age, actually, Stefan, and I think you can read my mind, that this would probably be the first question that I would say we, the implant placing dentists, ask ourselves, is the patient at an age where we can place an implant? Here, I would say it's clear for these two patients. In one, yes, in one, the answer would be no. Then a second thing that we always look for is the survival rate. And we also want to tell the patient, you know, how long will this restoration, how long will this implant survive? And we have so much evidence for survival rates. Then a third point, and I think this is really, really important and has to be discussed with the patient, complications. And here you see on the left-hand side, biological complications. And we know with implants, they are really difficult to handle. On the other hand, technical complications, usually they are not so difficult to handle, but we have to tell the patients, you know, there is a certain percentage of complications that will occur over time, and you will have to come back to the office and we will have to take care of it. But let's say we just want to look at the survival. So I can tell you, you know, you can choose either or, you can flip a coin. Both types of restorations, they survive over 5 years. And not only 5 years, over 10 years, you have very similar survival rates for an implant-borne restoration, but also for a resin-bonded restoration. So taking a decision can be quite difficult. So actually, what do we usually do as dentists, as academics, as researchers? We have to find a way how we can take the correct decision or the right decision, if you may put it. And what can we do? We can do research. And we set up a randomized controlled clinical trial. This is one of the patients. You can guess the site probably that has been treated. And we can do a clinical trial where we randomize patients into either the group resin bonded bridge or the group implant-borne restoration. And this has not really been done so far. So we have a lot or a big body of evidence for resin bonded bridges, as you have seen before. We have a big, very large body of evidence for single tooth implants in the anterior. Both kind of treatment concepts work really very nicely, have fabulous outcomes, very high survival rates, but we need to compare in order to answer the questions that maybe our patients have, because they want to know which one is more costly, which one hurts more, which takes longer, which has the bigger, you know, percentage of possible complications. And you really need to have a randomized controlled clinical trial in order to answer these types of questions. But I would like to take this a step further. I told you, we have to know, you see on the left-hand side the books, we have to know the literature, we have to know the evidence, we have to be kind of very good practitioners, clinicians that can also offer these types of treatments. But we shall not forget that at the center of each treatment is a patient. And this leads me to this prose, maybe you have read about this. This is the patient-reported outcomes. And there's a slight difference. There is a lot of times you may read PROMs. The PROMs are the measurements, the tools to measure the patient-reported outcomes. So the PRO is the type of feedback that we get from patients and that patients report directly to us. And these are gaining a lot of attention recently. So possible things that we could look at when we do research. What is the perception of pain? Let's say your patient that wanted to have or was asking you maybe for a recession coverage. Maybe she wants to know, how much pain will I have? How long will I have to suffer? When can I eat an apple after the intervention? How much painkiller do I have to take? Another question would be, how do patients rate their function of the teeth that we are giving back to them? How do they rate the aesthetics, so the aesthetic outcome of the treatment that we have performed? Or another question, and this is often asked, are you satisfied with the treatment? And I think this is really interesting. Today we had kind of a meeting with a PPI group. This is a patient and public involvement group. And we were discussing about these questions and discussing whether they really mirror what we would like to know from patients. And usually, you know, we read about patient satisfaction. But then patients told us today, what do you mean with satisfaction? You have a nice practice, your staff was really friendly, I had a very nice welcome, or what is satisfaction? And maybe we have to ask different questions, but we don't know yet. So for the time being, those are the questions that are usually asked when we do research.
Nadja, I have another question because
yes,
I find
please.
it very interesting. How important is a cost-benefit ratio? I mean, we have been talking about this in periodontics. We're saying non-surgical therapy costs less and it gives you the same result. How important is that for me as a professional, and how important is that for a patient? How would you rate that?
It's very difficult to answer, Stefan, and we don't really have data to answer this. You know, just today in this same group that I mentioned, we were discussing a study setup where one treatment would be a very fast treatment, like immediate implant placement, immediate restoration, compared with a treatment where you would place an immediate implant, but you would do a provisional restoration and then, you know, adapt the emergence profile and then do a final restoration. And then we were discussing with this patient group, what would patients want to know from us as clinicians? And patients would probably ask, which benefit do I have if I go for immediate? Mm-hmm. How much more does it cost? Or how much less does it cost? It's very difficult to tell. We cannot tell. We don't know.
Also, I have sometimes the feeling a patient wants to know, how much risk do I need to invest for this quick treatment? Because I sometimes have the feeling as a practitioner, if everything works well, this is what the patient expected. But if something goes south, it's my fault because I sort of persuaded the patient from this fast treatment. You get the point?
Yes, absolutely. I fully understand you. And this is, I think it's very, very difficult to kind of take the right decision at the right time or at the right moment. Absolutely.
Very good. Yeah.
Yes. But I think we have to just be aware that these questions exist and that we really kind of discuss with our patients. And then it is our duty, I would say, the people that do research, clinical research at the universities, we have to find out which tools we have in order to tell our colleagues, how can you anticipate? For example, we said, if you have a patient with a failing tooth aesthetic region, 1-1, and then you want to know how good has the outcome to be. We can probably not reach 100%. But will the patient be happy with 80%? We don't know. And how can we find out? Maybe it's probably very, very individual, I know. But still, it would help us a lot in probably taking the right decisions for the types of interventions that we can choose from. If you only think about tooth extraction and ridge preservation procedure, and then, for example, implant time points. You can place an implant at any time. Everything works. But maybe with some kinds of procedures, you have some benefits that maybe you want to give to your patient, or maybe to yourself, because you have an easier planning, you're less stressed, you are, better prepared for the interventions, you don't have that much risks, as you say, because maybe, we had this saying that we try to do one miracle at a time. And you're absolutely right. If you try to do many steps at one time and you fail, it's very hard even to find out why you failed.
Yeah. I mean, I find it so interesting because always if I do my consultation with the patient before the surgery, I always have a little bit of saying to make the patient comfortable. I tell him, I mean, if something happens during the surgery, I always tell my patients, I would always choose the most safest way. So if I don't expect the bone quality, whatever. And all of the patients say, yes, this is what I expect from you. And then I always say, no one ever told me, no. Then I please expect from you to do the quickest and the fastest treatment. They always say, please use the safest approach. And it's so interesting, right?
Very interesting.
And if you read the industry commercials, it looks like we should go for the fastest way.
And this is exactly what I perceive, what you describe. When I go to congresses, sometimes you hear this, like everything has to be fast and the patients really want us, they push us to do these immediate implants and immediate restorations.
They never.
And I always say, I don't have these patients.
No, me neither.
Or maybe, I don't know, maybe it's my fault. Or because when I explain to my patients, this is biology, we will have some physiological changes happening over time and we will have to, kind of anticipate what is going to happen. And if we take it slow, then we will have more certainty maybe to come to a certain end result that we would like to have. Patients will always understand. They never push me. But I don't know. But this is exactly what
statement. Very good.
This is exactly what I feel. Yes. So I just wanted to say that actually the research that we are doing now is also looking at these kind of usual suspects, survival rates, complication rates, and you name it. But we also look at these patient-reported outcomes, and even newer, maybe you have read about this, is the clinician-reported outcomes. So ClinROMs or OROMs, operated reported outcomes. Because these are going to be quite interesting as well. It's not the topic of tonight, but these clinician-reported outcomes are also very important for us. How easy is a procedure? How good do I feel? How much stress do I have when I do this procedure? And these are really things that are quite important when deciding on which steps you want to do. So let's go on. Yes, let's go here. Now, I would like to share with you, and this is really, really interesting. So if we look at patient perception, if we look at wide aesthetics, I would like to share this research with you. At our clinic, my colleagues did this interventional study, and they looked at different types of how a restoration was fabricated. And I will show you the two groups. It's again a randomized controlled clinical trial. In one group, you see the baseline picture before preparation of the tooth, design of the reconstruction, and in the same appointment, the restoration was milled and then inserted into the patient's mouth. Well, in the other group, the restoration was fabricated by a lab technician, so an indirect workflow, not a chairside workflow. The patient needed to come in for a second appointment for a try-in, and then hopefully at a third appointment, the restoration was inserted. You may have seen some clinical differences already. Now, Stefan, what do you think? Before treatment, patients were asked, what is more important to you? Costs or aesthetics? It was posterior crowns, tooth-borne crowns. What do you think is more important to patients?
I mean, you're in Switzerland. So it could not be cost. No, I'm joking. I guess they look after costs.
slight tendency that costs were more important than aesthetics. Quite interesting
I'm
for
not
us
sure
to know.
if in south of Germany the aesthetics in the posterior region would also be important, but I don't know.
Who knows? Who knows? I don't know. Maybe this is Zurich population. But actually, this second question, I think, is even more interesting. And I'm now testing you, Stefan.
Oh.
After treatment, patients were asked, how do you rate the aesthetics of your reconstruction? I will not show you the ratings. I will show you the clinical pictures.
Mm-hmm.
This one is the lab workflow. You have seen it before.
Yeah.
This one is the chairside workflow. You have a scale from 0 to 10. 0 is absolutely horrible. 10 is, I'm so fantastically happy with the aesthetics of my restoration. What do you think? How did patients rate?
Obviously, there is a difference, but I guess the patient would not notice the difference.
You want to see the results? Okay. Left side, a 10. We would give it a 10 out of a 10, right? For the left crown. For the right crown, we would maybe give it a 3 or so. I don't know.
Is that a professional rate now?
Yes. 9.5. You were so right. Patients cannot tell, or maybe don't care so much. So the outcome, of this study was so interesting because it was 1 single versus 3 appointments. The chairside even had less costs, but no differences for all the other measured parameters. So for the primary outcome, which was aesthetics, chairside reconstructions were non-inferior compared to lab-side reconstruction. Now we close our clinic because we ran out of work, because now we know patients don't need us anymore. Now we have to place implants.
Yeah.
But, this is really, now again, coming back to the case that you showed with the recession, maybe we want to do something that we think would be so nice. It would look so good, in a lecture, on a podium, at a congress. But maybe patients don't even realize the difference. Maybe they cannot tell. Maybe they don't care.
Yeah, sometimes I also have the feeling this is our world. And I mean, for the patient, this is an appointment at the dentist. And I think it's this different perspective. For us, this is the world. Yeah? But for them, okay, I have an appointment with my dentist and he needs to see the crown. Full stop.
Yes.
I think there's different perspectives, right?
Yes. Yes. And it was very interesting. Actually, again, today we had this discussion with this patient group. And one patient said, I cannot be in a dental chair for more than 1 hour. And I mean, I told her, I never ask my patients whether they can sit in my chair for more than 1 hour, because I mean, if you have to do a surgery, sometimes you need 2 hours. Maybe you need 3 hours. I would never ask them. And then they said, we were talking about the time points when you should ask patients how they perceived a certain treatment. And usually we would ask at wound or suture removal, how was the pain during the last week? How was the pain medication intake? And the patients told us, maybe this is not the right time point. Maybe you should ask me now, because now I'm really happy I can leave your chair.
Yeah.
And
good point.
It was really interesting to have this discussion.
Yeah. I also have sometimes and maybe a different perspective. I also started with that to tell the patient, okay, this would be an approach where you have a little more pain, and this would be an approach where you have a little less pain. And a lot of patients told me, I don't care. I want the safest solution. I mean, 1 day pain more. I mean, what is it in my life? You understand? I mean, when you compare that to orthopedics or back pain or whatever, it goes away. Is that what they say? So it's so funny how they sometimes think, right?
Very interesting. And we have to find out, maybe to one patient. If you think of soft tissue grafting from the palate, like you mentioned before, You know, you have these patients that complain, it was so horrible, and you look at the wound healing and it looks just perfect.
Yeah.
And then you have these other patients and you look inside of their mouth and you go like, okay, maybe it could look nicer. And they go, no, I didn't have any pain, no problem. You know, I was eating everything. And you're like, how is this possible?
True.
You know, it's so individual, but sometimes it's so difficult to foresee how a patient will perceive something.
True.
And I think that's the difficulty. And that's the interesting thing that we are discussing now. Yes.
Yeah.
So should we go to have a look at the perception of pink aesthetics in comparison to white aesthetics? And I just want to show you also a clinical study from our team where they try to assess these threshold values. It sounds a bit complicated. It's not so complicated. And they wanted to see whether people, different types of groups, would see a color differentiation or a color difference. And actually this research was done in the aesthetic area, now not the posterior, but the anterior area. And it was done both with soft tissue, but also with teeth. But we're going to have a look at the results for the soft tissue, so for the pink color. Now, the perceptibility, and I will explain later on, and the acceptability were evaluated by dentists, being one group, by dental technicians, being the second group, and by lay people, being the patients. Now you can already think who might be better at seeing, you know, perceiving color differences. And this was one of the clinical situations they would show the patients. You will see a restoration in the anterior area. You see differences in the white aesthetics, but now we're going to focus on the pink aesthetics. And you see kind of a deficiency, but also adhesence in region 1-1. You see a more bluish color compared to position 2-1, where we have kind of nice color and texture of, I would say, a healthy gingiva with a nice volume. Now patients, technicians, and also professionals were asked, is there a color match or mismatch? And these are the results for perceptibility, meaning, can I detect a color difference? And on this scale, you can see that technicians were a bit better at perceiving a color difference compared to dentists. And lay people were not as good. So dental technicians showed the highest sensitivity when it came to perception. This only tells us whether a patient sees the difference. Maybe we do see the difference, and here you can see that maybe it takes a bit more for patients to see the difference when it comes to pink aesthetics. Now, the second question was even more interesting. You still see the yellow lines for the perceptibility. Now, the groups were asked how long will they accept a certain color mismatch? How long are they still happy with a possible outcome? And this is what happened. And you can see that the acceptability was much, much higher than the perceptibility, meaning that patients would maybe see a difference, but they would still accept it. And this is really interesting. And I mean, we cannot tell how much they will accept, but it is quite interesting to know. And as we have discussed before, Stefan, maybe patients don't want to have the 100% result. Maybe they are happy with the 80% result. Maybe they do see a difference if we show them, you know, these pictures that we do have, where we do this pink aesthetic and white aesthetic assessments without the lip, you know, very nice pictures, and we see everything blown up in a huge size pictures. Patients, you know, they have a lip and they function during the day. Maybe you give them a mirror and they have a look, and then they accept a lot more than maybe we would accept. And I think that's quite important to discuss with the patients. I don't want to say we should not treat the patients the way we did until now, because they don't see it anyway. This is not what I want to say, but as you said, maybe we have to be aware that some steps are quite invasive. Some steps come with a lot of morbidity. And we have to be aware that maybe to us it's really important, but maybe not so much to the patient.
Very good point. Nadja.
Yes.
There are many questions coming from the audience. Maybe I hand over some of these questions to you. We have actually quite famous listeners to you. We have Irena Seiler here. We have Mario Romandini here. We have Howie Gluckman here. Hello to all of you. There are questions. Howie has a nice question, which I like. Howie, by the way, you also get an invitation here. Does the treatment options which you show the patient differ when it comes to the how they perceive a treatment? I think what Howie means is, if you know that this patient maybe doesn't like so much invasive procedure, would you be more, would you recommend him a less invasive procedure, or would you still go for the gold standard?
I would say I would try to adapt my treatment plans, plural. If I know the patient, or the patient comes in and already tells me, you know, I don't want to have a very costly treatment, I still try to offer different treatment options. But yes, I would definitely try to adapt. I would probably still inform the patient of the, how did you say, gold standard, or of the maximum, because I think it's my duty to inform the patient fully transparent. You know what I mean? But I would,
absolutely.
Yes.
There's another question from Mario. How important, coming back to a more from a case perspective, how important is a tooth position? I mean, I guess what he's thinking of is when you have to extract the tooth, you maybe have a buccal dehiscence. How important is this when it comes to judge your treatment procedure? Would you be more invasive in that perspective? And how would you rate the person's perception with this?
I think it's a very good question. Yes, I think it probably does play a role, because, you know, when we say we want to restore an anterior segment, we always try to, you know, go for the maximum outcome, for the best possible outcome. But maybe we just have to keep in mind that sometimes maybe this best possible outcome maybe comes with risks that we take if we have to take several steps. So I would probably also discuss with the patient, you know, how important is it to you, you know, let's say in the posterior area, is it important for you that you can chew? Is it important that you have a closed gap? Is it important to you that it's just white? But maybe it's not so important, you know, the pink-white aesthetic, I would say, in the posterior. And this is what I would discuss with the patient. And then also, you know, for the anterior area, if the patient shows everything, then I probably have to discuss with the patient, you know, we should have to go for the, you know, the full repertoire that we do have in order to really reconstruct what has been or what we have lost over time. So yes, I would say I would probably, yes, I would make a difference between different sites or regions.
I have a little bit, it's always a little bit the last question. I hope I haven't too much interrupted you with your content, but we're also a little bit from the time-wise, we're discussing so much. I hope it's fine for you if we do the discussion now. I always have a little bit the feeling sometimes that patients come in and the situation looks like a mess. And now maybe the patient expects me to make the best out of it, or I expect from myself to make a perfect result out of it. But he has been living with this situation maybe for 20 or 25 years. Is that also something which comes into your mind when you think of these cases? Like I've been thinking about that case with the lady in the beginning you showed. I mean, it didn't look nice. Probably everyone knew her with that smile. So I always think to myself, don't I change a little bit also the character of the patient if I make it that perfect? You get my point a little bit?
And I'm very happy about it. I mean, several things come to my mind. First of all, it has been, I would say, the philosophy of our clinic that we would always try to reach a natural result that would fit with the patient's existing dentition. And this is always something that we also communicate with the patient first thing. Together with the dental technician, we have a first or a second appointment, and we communicate to the patient, you know, we would like it to look naturally, so people will not look at you and say, oh, there is something new. Maybe with this first patient, people would realize, and I would be happy about this, to be honest. On the other hand, I have recently been lucky enough to be a part at the EFP workshop with CDP and CEPA, and it was on these patient-reported outcomes. And actually, the systematic reviews that were performed would find these pros, but the thing that we realized were that, first of all, a lot of evidence that we have in this regard lacks a baseline. So we are usually lacking baseline data coming from patients, and the tools that we have to assess what we want to assess, for example, pink and white aesthetic scores, they were not developed for the things that we want to assess now, and they were not developed to be used, you know, by patients. So, you know, we could talk about this topic for many more hours, and there are some really nice surgical RCTs, evidence on grafting procedures. One is from the Dutch group and one is from a Swiss group, showing that the professionally assessed outcomes, they don't really match with the outcomes that are assessed by patients. And we may not have the right tools to assess these outcomes. So maybe you are not happy with an outcome, but the patient, as you said, the way the patient came, he's been walking around with this forever, and now the papilla fill is not 100%, but the patient is still happy because it looks so much better than before. Maybe you are not happy because, you know, you don't have a full papilla fill and you cannot tick one of the pink aesthetic outcome boxes. But it's just the literature or the tools that we do have now are not sensitive enough to really tell us what matters to patients.
Yeah.
Not yet.
I think this is a very, very good statement at the end. Nadja, time is unfortunately up, but we need to get you back. You have so much content, and it is such a topic where everyone discusses, and you can read the comments in YouTube. The people love it. They congratulate you. They say it's such a relevant topic, and it's so helpful. And I think maybe we can conclude from our session that we as professionals, and maybe also we as speakers, we should take a step back and be more careful about what does the patient want, or when is he satisfied with the result. That's at least what I learned from this day, or what I also learned the hard way at being a dentist. The only thing, maybe this is the last statement I want from you. Don't you think this is difficult for our young clinicians? Because this is so hard to judge. They go to the Congress and they see a perfect papilla fill and they want to redo it, maybe in the 75-year-old man with a low lip line. And you think perceptions and expectations, they go completely cross. Don't you think it's difficult for the young?
I think it's very difficult. I would say it's also difficult for us who have a lot of experience. Maybe we are a bit more sensitive to these type of questions because we are not so focused on the techniques that we are doing on a daily basis. But yes, I mean, also when you think of social media and all these pictures that you see, you know, these perfect clinical pictures and these smile lines and everything. And maybe this is not what patients really want, and maybe this is not what we want to offer, but I think each of us has to individually decide, you know, where do I want to go, or in which patient do I want to go for the 100%, and in which patient can we maybe go for the 80%.
Yeah, but maybe also we need something. This is maybe something also for your science. We need to give our young clinicians a tool or a help. Because I had the same problem. I was looking for the perfect papilla in patients who didn't want the perfect papilla. Yeah, so anyway, Nadja, it was great. I could talk with you for another hour. Howie is also saying it's a fascinating topic. I agree. It was perfect. I mean, I would like to thank you on behalf of the EAO. Thank you on behalf of all the people logging in. You can read the comments later. Please, everyone, come to our annual Congress in Monaco in fall this year, and subscribe to the YouTube. I think we have over 11,000 subscribers now for the YouTube channel, which is great. And with this, I would like to thank you again, Nadja, on behalf of the EAO for taking the invitation and also for making this a beautiful lecture, and everybody loves it. So with this, thank you again. Greetings to Zurich, to Switzerland, greetings to all around the world. Ciao, ciao, bye-bye, and thanks again, Nadja. Ciao, ciao.
Thank you so much, Stefan, and you and everyone. Thank you. Good night.